This is Mary Shoutwell recording Chapter 2 in Law and MacDermid, Evidence-Based Rehabilitation, A Guide to Practice. This PowerPoint is going to be pretty short because basically what the premise of the chapter is talking about where you are in your career trajectory in terms of your ability to, I guess, absorb or understand evidence-based practice. It also dips the toe in kind of talking about how it is we relate to other disciplines in terms of evidence-based practice. So our objectives are to understand multiple levels at which our discipline develops, to understand how evidence-based practice develops based on your point in your career, to understand responsibilities of oneself as an evidence-based practitioner and a member of a discipline, and to understand challenges in developing the evidence. So first, the next slide talks about our responsibilities. So why is it we even teach you guys evidence-based practice? Because we know a lot of you are interested in treating patients. So the point is, though, we don't want to repeat or pass down techniques or interventions or uses of a particular assessment tool just because that's the way the person who trained us did it. That is kind of the old world apprenticeship model. So the job of any professional and any practitioner, and as someone who claims to be evidence-based, is to challenge current beliefs. So while we don't want you to go to every fieldwork site and say, why do you do it this way? What's the evidence? You don't want to make people upset. We do want to ask some of these questions and challenge current beliefs. We want to talk to our colleagues about why is it that we do this with people with stroke. My CI taught it to me, but is it still relevant? Is it still accurate in terms of the evidence available for it? In addition to challenging our beliefs and talking with other professionals about our beliefs, we also want to test our own hypotheses. So even if we're in a clinical environment and we're like, I wonder if that treatment really valid, we may want to partner with the university to help them study something when you become a clinician or are a clinician, because sometimes you can't do it by yourself. You might not have the time. But we need to figure out ways to test our hypotheses and our new ideas and new interventions. So the next slide, there's a table on page 19, table 2.1, that basically talks about where people are at in their professional development. And in other courses, you will learn about this, what they call the novice to expert continuum. And at the novice level, basically, it's like you don't have experience. The expert level, there's different years that are attached to that, but typically it's 20 plus years, 15 plus years. So let's sort of set the stage there. But new OT students are at the pre-service experience level. And so their job in terms of evidence-based practice is to learn the foundations of the discipline, to learn foundations of intervention, to become aware of one's own beliefs about specific interventions. So, you might be learning about a specific intervention in school, and you say to yourself, is that really true? Or, should I believe everything my teachers tell me, in other words? For the test, you do have to give them the answer, hopefully, they're looking for. But in discussion, I think all teachers and faculty and OT scholars want us to question what it is we're doing. So to question, does that really work? Is that really a valid intervention? So at the novice level, which is like the new grad to maybe 3, 5 years experience, what they begin to do, because now you have multiple cases to look at, so it's not just the one stroke you saw on fieldwork. It's maybe over the first 3 to 5 years, I've seen 20 of the same type of stroke. And so I begin to understand patterns of the way recovery happens, for example. Or I, have a wider repertoire of children with autism. Now I begin to be able to generalize my ideas and to identify or determine which methods are effective and which ones are ineffective. And I also have the capability, because now I'm working with patients and I'm kind of in charge of my caseload, I can also begin to test my own knowledge and beliefs on my own caseload. So I know people who kept data on their caseloads, what assessments they did, what interventions they did, and they just kept like a folder with no names, but just the diagnosis and, maybe other data. But that's where you begin to evaluate your own effectiveness as a clinician. Um, and usually around 3 years, because things get more routine for you, you can really begin thinking about evaluating your own effectiveness. Now, the experienced professional, the goal there is to establish methods. So this is like, 5 to 15 years, 20 years. And these people are going to be maybe in charge at your agency of developing quality improvement indicators. Well, how do we know people have improved in our agency or our facility? And they're also going to be the people like typically presenting at meetings or conferences, hopefully publishing stuff, about successful and unsuccessful interventions. And then lastly is the expert professional period. And these people are typically the people conducting the research, supervising the research, and evaluating the effectiveness of the interventions. So these are your people who are maybe managers. These are people who maybe are scholars, academics, researchers, maybe even like a quality improvement coordinator in a hospital or an agency. The next slide just talks about an example of a case that was done, I believe, in Australia. And what they did, this is described on page 23 in your book. And basically what they did is they studied clinicians longitudinally over a period of time, from the time they were a student to more experienced clinicians. I think it was like an 8-month period, and they went through some training on evidence-based practice, and then they interviewed the people and did some observations. And what they found was that students who were formerly taught evidence-based practice, did better at applying evidence-based practice than did experienced clinicians. So the reason we bring this up is because some of you may go to field sites and you may say to your therapist, why do you do that? And they might not be able to articulate why they do it because they've been doing it so long. Maybe they've been doing it without thinking. So we really need to begin to kind of think about where people are at in their developmental career. What they also found is that experienced clinicians were most consistent with the two final steps of evidence-based practice, where they could make decisions and they could reevaluate the effectiveness of those decisions more effectively than student OTs. Student OTs tended to be able to form a question and be able to find the literature more so than the experienced people, but students had a harder time making a decision. So how is it, the next slide talks about, how is it we become an evidence-based practitioner? Well, first, we need to be able to develop a PICO question. We need to be able to develop effective research questions. We have to not accept everything as gospel truth. We have to kind of question everything. And sometimes that can be exhausting, but part of being in a profession is to constantly be learning and questioning what it is we're doing. So first, we need to learn to write focused questions, and figure out what it is we need to learn to answer those questions. And then we need to find literature and appraise that literature in regard to our topic area. Now, I do want to say that in many agencies, or even if, say, you work for a private practice, there are these things called area health education consortiums. It's a big word. It's a federally mandated program. And basically what it is that every medical center, even like a, sizable community hospital in a rural community, has an AHEC. An AHEC is Area Health Education Consortium. And as part of that AHEC, there is usually a medical library, which typically is housed in a hospital or really close to a hospital in that community. AHECs are really interesting agencies because sometimes they fund scholarships and training, and they're just a really cool. A lot of people don't know about them, but anyway, you could go to an AHEC librarian as a member of that community. You don't have to work in that hospital. And say, hey, I'm looking for literature on sensory integration. Can you help me? So librarians are wonderful, and they can help you find articles, and you have to do the appraising of the articles, though. That's up to you. After you appraise the research, then your job is to use these skills to inform practice, not just for yourself, but for other people. And that's where it gets hard. So you have to, on the one hand, be careful not to point your finger at other people and say, what you're doing is not evidence-based. But on the other hand, is to quietly, or maybe through a journal club or some other way, to help people understand the current stuff in evidence-based practice. And then we need to help people as we gain more experience, that is, how do I say this? Be able to implement these new interventions and be able to talk to management, be able to talk to clients, be able to talk to funders about the evidence to support what it is that we're doing in our practice. The next slide talks about challenges, which I've talked about some of this already. It's on page 22, with evidence-based practice. Because what we do in occupational therapy very often is customized, and the interventions that we do are very, it's a good thing. We're client-centered. We do what people need or want to do. But the problem is when we try to read and compare studies about intervention, the intervention may not have been the same intervention. Therefore, the generalizability of our research is sometimes problematic. Secondly, if I'm working, 40, 50, 60-hour week, full time, I have a family, it's hard for me to disseminate information about the evidence that I found. So I really implore you, once you get out there in the real world, to contact whatever university or universities that are near you and talk to the faculty and say, I've got an idea for a project, or I have this data, but I need you to help me put it in an article, and you can, partner with the university. So we have an obligation, even though it's challenging, to disseminate information in an accessible way to clinicians, and not just clinicians, clients, because clients don't always understand why we're doing what we're doing with them. A lot of times OT seems like such common sense. People say, I'm paying you to teach me how to dress myself. And so we need to show them that, hey, if you didn't have somebody, it would take you a lot longer to relearn these skills without us present. So, that's the kind of stuff we need to help patients, funders, family members, and management understand. Okay, the last point is that, again, as mentioned earlier, we can't go in there pointing our finger at therapists saying you should be doing this way, or that way. But hopefully we can politely help them try different interventions that are based in the literature, or ask our managers, hey, can you send me to this course on this new intervention that seems to have some evidence to support it. Okay, so what are some conditions for practitioners and getting practitioners to change ideas and not just do things the way they've always done it? Well, first, we need to be ready for change. We need to accept evidence-based practice as a necessity. So some of it is an attitudinal thing. As students, you are open to this, but some practitioners who have complicated personal lives, or they're near retirement, they don't want to learn something new. So they may be more resistant to implementing evidence-based practice. We need to have your own personal expectations. Like, you can't be reading journal articles all the time, but do you read an article a week? You need to. And what is your organization's expectations for searching the literature, finding articles, exploring relevant interventions? And which brings me to the third point. What is the availability of support? Like, so does your manager support this happening? Will they give you time? Do you get any money to go to continuing education? Do you get time to go to continuing ed if they're not going to give you money? And then lastly, what about interprofessional evidence-based practice? So that's where we begin to look at, well, do all these disciplines need to be working with somebody at the same time? Maybe we need to have PT work with them, get them strong, and then we'll implement the functional activity. What about speech pathology? So we need to think about our companion disciplines, particularly PT, OT, speech, education in the school system. Those are the big ones we really overlap with. Sometimes athletic trainers or exercise science people in a cardiac rehab kind of context. But really begin to think about, are there interventions that are interprofessional that might be more beneficial to our clients than individualized interventions?